Hi, and welcome everyone to today's presentation. I am Karen Thompson, a registered nurse of 38 years and currently working as a clinical consultant in the home care field. I sit on the executive of the Community Health Nurses Initiative Group in Ontario. Today, I am pleased to speak to you about care planning and care coordination in home health nursing. The objectives for today's presentation. First, I'd like to discuss how home health aligns with the healthcare service delivery team. I'd also like to provide you with a brief overview of the community health nursing standards and how the role of the home health nurse has evolved as a specialist. And then to discuss the realities and challenges in home health care by sharing a day in the life of the home health nurse. First, an introduction to home care. Home care has evolved by responding to changes that have occurred in the hospital sector, things like bed closures, increase in ambulatory care clinics and day surgery, and also in the long-term care facility sector, like waiting lists for beds and limited availability. As a result, home care has emerged as an integral component of Canada's healthcare system and essential to its sustainability. Home care uniquely functions as a bridge between the various settings of care, including the acute care hospitals, emergency rooms, supportive living, long-term care homes, and the physician's office. These close linkages enable home care programs to meet clients' needs in an individualized and comprehensive manner and go beyond physical and mental health care to engage social supports as well. Home care is an array of services for people of all ages, provided in the home, workplace, schools, and other community settings, such as clinics, that encompasses health promotion and teaching, curative intervention, end-of-life care, rehabilitation, support and maintenance, social adaptation and integration, and support for the family caregiver. The provision of home care allows people of all ages the opportunity to recover or manage their healthcare issues and age at home, surrounded by family, friends, and their community to which they can continue to make a meaningful contribution. Home care services help people with a frailty or with acute, chronic, palliative, or rehabilitative health care needs to independently live in their community and coordinate and manage an admission to facility care when living in the community is not a viable alternative. Publicly funded home care in Ontario is administered by the Community Care Access Centres, CCACs. As of January 1, 2007, there are 14 CCACs throughout Ontario. For publicly funded care, the Community Access Centre, CCAC, is responsible for deciding who receives care, what type and level of care they need, and for how long. The CCAC case manager is involved at all times with client's care. Home care service providers deliver the care to the client as they are requested by the CCAC. Home care service providers are contracted by government, community care access centers, institutions such as hospitals and long-term care facilities, and private individuals. In addition to government-funded care, people wanting to stay at home may access services by purchasing services privately or accessing private insurance or benefit plans, example, their private health insurance. The Ontario Home Care Association in 2009 estimated that 150,000 Ontarians privately purchased an additional 20 million visits or hours of home care services annually in order to remain at home. Privately purchased home care service often provides the vital few hours of care and respite that enables families to continue their caregiving responsibilities, which many are fulfilling while raising their children and holding a job. Services within home care include nurse therapy, including physiotherapy, occupational therapy, speech-language pathology, medical supplies, and equipment in order to provide quality health care and support services to clients of all ages in their homes, schools, offices, and assisted living centers 24 hours a day, 7 days a week, 365 days a year. Home care service providers contracted with the CCAC are usually accredited with Accreditation Canada. Why is home care so important? In Ontario and Canada, the importance of home care is becoming more and more recognized as a major foundation upon which other parts of the health care system rest. Home care does not exist independently of the rest of the health care system. It is pressured to meet the demands of the acute care system to support durable discharges, and it must support primary care objectives to maintain very sick people in the home and prevent emergency room presentation and admission. Home care providers are challenged to support sicker and more acute clients and also to meet the needs that are culturally, clinically, and linguistically specialized. This requires the evolution of home care provider organizations that can meet a variety of demands and standards. This understanding of the maturation to the home care system is critical as we experience turbulence during its growth and expansion. Most people intuitively accept the fact that home care is important to allow people to live at home with the support they need to recuperate, function independently, or face the end of life. As home care expands, it is better able to fulfill its function of preventing premature institutionalization of the elderly or medically fragile person and supporting people of all ages to enjoy greater quality of life in their own home. Romanoff claims there is growing evidence that investing in home care can save money while improving care and the quality of life for people who would otherwise be hospitalized or institutionalized in long-term care facilities. This year, the Drummond Report states, increase the use of home-based care where appropriate to reduce costs without compromising excellent care. For example, home-based care should be used more extensively for recovery from procedures such as hip and knee surgery. Deb Matthews, our Minister of Health and Long-Term Care, stated, nurses make an incredible difference in patients' lives and play crucial roles in our health care system, which is why the government has chosen to invest precious health care resources in new nurses, including many working in community and home care. So the healthcare delivery team. So there's always a team of people providing care to the client and their family. As you can see from this diagram, in the inner circle is the client and family, the focus of care. The home care service provider has nurses, therapists, unregulated workers, supervisors, and assignment coordinators who are responsible to ensure the client receives the right care at the right time by the right person. The outer circle represents all others in the community that might be accessed to support or be used as a resource for the client and their family. So what is a home health nurse? A home health nurse is a community health nurse who combines knowledge from primary health care, including the determinants of health, nursing science, and social sciences, focuses on prevention, health restoration, maintenance or palliation, focuses on clients, their designated caregivers, and their families, and integrates health promotion, teaching, and counseling in clinical care and treatment. A home health nurse is a community health nurse who initiates, manages, and evaluates the resources needed for the client to reach the optimal well-being and function. Provides care in a home care clinic, the client's home, school, or workplace. They are nurse practitioners, registered nurses in extended class, licensed to order and interpret diagnostic tests, communicable diagnoses, prescribe pharmaceuticals, and perform specific procedures, are beginning to practice within home care as well. Community health nursing has evolved to become a specialty within the practice of nursing that describes nurses who work outside the hospital or long-term care facility. Nurses in this specialty promote, protect, and preserve the health of individuals, families, groups, communities, and populations, wherever people live, work, learn, worship, and play in a continuous versus episodic process. Community Health Nurses Standards. The Community Health Nurses Standards were developed by the Community Health Nurses of Canada and help to articulate what the community health nurses do for their clients and allow for the recognition of home health nurses as specialists with the Canadian Nurses Association. From these 7 standards, home health nursing competencies have also been developed. The first certificate exam with CNA was written in April of 2006, and as of 2011, there were 694 community health nurses who received certification. The Community Health Nurses Initiative Group, CHNIG, is a special interest group with the RNAO and has its mission to act as the voice of community health nurses influencing the healthcare system and health and social policy in areas which affect the work of community health nurses and the public they serve. The first standard is health promotion. Integrating health promotion into their practice to enable people to increase control over and to improve their health. What can be taught to clients that will assist them in taking control over their health or cope with their chronic illness? Who can be contacted to assist clients in leading a healthier lifestyle? Would clients benefit from participating in a community program? What would clients benefit from learning all care options available to him or her? How can clients collaborate or make use of their local resources to prevent injuries, diseases, reduce their health risks, or maintain their health status? Second standard, health prevention and health protection. The community health nurse integrates prevention and health protection activities into practice to minimize the occurrence of disease or injuries and their consequences. The third standard, health maintenance, restoration, and palliation. Systematic and planned methods to maintain maximum function, improve the health and support life transition, including acute, chronic, terminal illness, and end of life. The fourth standard is based on professional relationships. Community health nurses connect with others to establish, build, and nurture professional relationships in order to promote maximum participation. How could this be done? They build trusting relationships between the client and the nurse and show respect and dignity towards clients, their decisions, and beliefs. The fifth standard, capacity building. Community health nurses build individual and community capacity by actively involving and collaborating with individuals, families, and groups. Examples of how this is done. Perhaps how could a case conference benefit the health of clients and families? What do clients need to know to take part in healthcare decisions? What can caregivers do to help clients achieve a desired health status? Does the client need other services that we cannot provide? What can be done to increase the client's capacity to increase their skill, knowledge, and willingness to take action on their own in the future? The sixth standard, access and equity. Community health nurses facilitate access and equity by ensuring resources and services reach the people who most need them. How is this done? They advocate for appropriate resources for their clients. They can assist clients and family in seeking respite as needed. And they work with the case manager to provide the best possible care that responds to the client's needs. Seventh standard, professional responsibility and accountability. Community health nurses demonstrate responsibility and accountability as a fundamental component of their professional and autonomous practice. How can this be maintained? They review their skills and competencies that they must maintain or update. They seek learning opportunities in various areas, such as technical, knowledge, experiences, legislation. They demonstrate a professional conduct towards their colleagues, students, and novice practitioners. They take personal responsibility for seeking information from various sources that enables others learning through shared experiences, coaching, and mentoring. A community health nurse engages in open and honest interactions with colleagues and encourages active participation and commitment from others in the pursuit of common goals, to understand their roles, set expectations, share information, and build consensus. I would now like to share with you a typical day of a home health nurse. Just like nurses in other sectors, the home health nurse is responsible to plan and coordinate the client's care by implementing the nursing process. Notice the variety of clients that one nurse could see and the processes involved that are similar or different compared to other sectors. So a day in the life. I'm going to use my name and keep everything very confidential here. So Karen is a home health nurse. She begins her day at her own home by reviewing the assignment that she downloaded from her agency's website the night before. She organizes the documents, supplies, and equipment in her car that she will need for the day. She realizes the evening nurse has left her a message about one of her palliative care clients. She currently has 5 on her caseload. The client had a rough evening with pain management. Several options were discussed over the phone, and Karen will need to visit today. Now, this is an unexpected visit. To complete a pain assessment, and based on this assessment, will need to contact a physician. Karen already has 9 clients, and we do call them clients in the home, not patients, to see today. So she will have to rearrange her 10 o'clock visit to later in the day. So, better phone the palliative care client and inform them that she'll be coming around 10 o'clock, and call the other client to let them know she won't be there until about 3 o'clock. Thank goodness that client didn't have any plans for the day, that they will be home, and they agreed to that change in time. Karen gets into her car and drives 5 kilometers to her first visit of the day. This client has been home for 2 days now. He's diabetic, on insulin, has peripheral neuropathy in their feet, and loves to smoke. Karen has to teach him how to properly administer the insulin. He needs to do some teaching about diet and the effects of insulin because he never has good glucose reading. That's when he does take them, not 3 times a day as recommended. And his eating habits are very sporadic. He doesn't like to cook. There's no diabetic diet being prepared and delivered for him like in the hospital, where they said he was eating okay and his blood sugars were stable. When she arrives, she kindly asks him to put out a cigarette for her sake and his, of course, discusses what he has planned for breakfast, watches as he prepares his insulin, and he tells her that he's going to reuse this syringe and needle for 2 days to cut down on costs, and asks to look at his feet. She didn't get a chance to do this yesterday. For the inspection of his feet, she notices that he has dirty socks on, and he has the start of a diabetic ulcer. She knows he's very susceptible to having this ulcer infected, and will need to plan interventions to prevent this from happening. But how compliant will he be? Will he keep clean socks on? What wound care products will work best for this ulcer? Will he eat properly? Will he take his insulin as scheduled? Will he cut down or stop smoking? With all this information, Karen needs to develop a really good care plan with some client-centered goals that will be collaborated on. Next client lives 2 kilometers away. This client had an above right knee amputation, and on his referral, the case manager noted he was MRSA positive. Karen has been seeing him daily for 4 days now and knows she must use the correct precautions. The company policy states clients with MRSA need to be seen at the end of the day, but this client has BID visits, so she sees him in the early morning and late afternoon. She puts on a disposable gown, the gloves, thank goodness there's a box in the home, and some goggles. The wound has a large amount of exudate. His shirt is soaked. How does this need to be laundered in any special way? And she has to flush the wound with normal saline. Sometimes the client has to make that saline. She hopes he has followed the instructions on how to make his own sterile salt water, and covers the wound with an appropriate product to contain all the exudate. Karen had to discuss the best product with the CCC case manager, as initially she did not want to okay the use of this expensive foam product as suggested. Karen knows that she will need a doctor's order to obtain swabs, as the client must remain on precautions until 3 sets of negative swabs are to be obtained at least 1 week apart. So she checks the chart. No orders were received when the client was discharged from the hospital. Who should she call? She tries the doctor at the hospital, but can't get in touch with him as he's in surgery all day and won't be back until much later. So a message is left for him to fax the order to the office. For the nurse to get the order, she'll have to travel back to the office next morning to receive the fax, unless she has a fax machine in her home. She must remember to call the office first thing tomorrow to see if the fax is there. Once she gets the order, then she has to arrange to make sure that the supplies are delivered and who's going to send that swab to the lab. On to the next client. This client has cellulitis in the lower leg and is on IV antibiotics. She changes the cassette in the pump and assesses his leg. His cellulitis is spreading. She calls his doctor, who will meet the client in the local emergency department. She fills in a physician update form to summarize the current treatment and her assessment findings. While in the emergency room, the client's pump starts to beat. The nurse there isn't quite sure what to do and calls Karen, who has to explain how to turn it off. While in the emergency room, the doctor changes the IV antibiotic, gives the client 1 dose, and sends him home. Karen gets a call later in the day that she'll have to go back later, only once when the community pharmacy has sent over the newly prescribed antibiotic, and they're not sure of what time that will be. When she does return later that day and administers the next dose, the client starts complaining of chest pain and his throat feels funny. Is he having an anaphylactic reaction? It looks like it. Karen retrieves her adrenaline from the nurse's bag, checks her medical directive, and prepares and administers the injection. Again, she has to call the doctor and let him know what happened. Of course, this is now about 6 p.m. and the original doctor's not available. So she has to explain the whole situation and wait for her instructions. But now back to those morning visits. Better go to the client who had poor pain control last night. To provide good palliative care in the home, the expectations are to complete an ESAS, an Edmonton Symptom Assessment Scale, and the PPS, the Palliative Performance Scale. It took some education to get to understand how to use these tools, but they do help with assessing the symptoms that are usually involved with palliative clients. Karen does a complete pain assessment and recognizes that the long-acting dose of opioids will need to be changed. She cannot do this, so she has to put a call into the palliative care physician. She provides the total 24 dose of opioids taken, the current long-acting dose, and where the client rates the pain on the 1 to 10 scale. The physician orders a higher dose. Karen instructs the client that the pharmacy will deliver the new pills, and when they come, not to take the previous pills, but only the new ones every 12 hours, and to keep a diary of the level of pain. Of course, she documents all her health teaching, assessment, interventions, and the outcomes. Client number 5. It's now about 11:30 in the morning. This lady has a malignant pleural effusion and has just had a pleuric catheter inserted. This is new, and Karen has to learn how to drain the pleural effusion every 2 days. She attended an in-service from the manufacturer, arranged by her office last week, but this is the first time she'll be setting up the drainage system. So she hopes that she can remember how to do it. There's no other nurse in the home with you for moral support, and that big policy and procedure manual is back at the office. Another big concern is the potential risk for infection at the insertion site. This poor lady has a low neutrophil count, so she must remember to check the temperature and remind the lady to check her own temperature a couple of times a day. Again, cleaning around the drainage tube will require good technique. Get out the boiled pot to use as a dressing tray, reusable forceps, and sterile homemade saline. There's not always sterile scissors in the home to cut the floor or gauze. The client does have an extra pair that Karen will wipe with an alcohol swab prior to using. So where are those alcohol prep packs? Oh yes, she has some in her nursing bag. This client really wants to talk about her advance directive and keeps asking questions about how her life will end. Karen really tries to do her best when she's with her, but thinks and hopes that a social worker could see the client. She'll have to contact the case manager at CCAC and make those arrangements. The next client is Emily. She's a 4-year-old girl with cerebral palsy who lives with her parents and has developed a wound infection. Because the infection is caused by resistant bacteria, Jennifer dons a gown and gloves to care for Emily's wound. Jennifer sees the wound is now progressing and needs a different wound care product, so she goes to her car trunk and retrieves a more appropriate dressing. She updates the care plan to reflect this change. Emily is receiving IV therapy, so Karen also replaces the solution container on Emily's IV pump with another 24 hours worth of antibiotics and reprograms the pump. She carefully assesses the central line site and reviews with Emily's parents the signs and symptoms that would indicate the central line has become infected and would require a call to the nurse. After lunch break, there's a new client to see. This client had a stroke with some rehabilitation, and the CCAC is suggesting to go in to check on her medication, check on her general medical status, and how well she is coping. Hopefully, physio and OT will be going in soon to do the home assessment and set her up with the appropriate equipment and exercises. The husband will be the primary caregiver and will have to help this client to toilet, bathe, and get dressed. Geez, I wonder how well he will cope with this, especially at the age of 82. For the initial visit, Karen is expected to complete an ARI screening, to get a consent to treatment sign, discuss the release of information policy, and have her sign it, provide her with the privacy policy, complete a full electronic nursing admission assessment, and a safety assessment of the client's environment. She will then identify the priority problems and outline all the interventions to have successful outcomes of care. This will normally take 90 minutes to 2 hours. To get to know the client and the family quite well, and we pride ourselves in providing holistic care. Safety of the client in the hospital is really big right now, but since Karen works with an accredited agency, she also has to consider safety of the client in the home. So, the safety assessment requires inspection to reduce and eliminate the risk of the external and internal environment, both for the protection of herself and of the client. With this admission, Karen knows that completing a medication reconciliation will be required. She will need to spend time reviewing all new prescriptions and comparing to what was being taken prior to going into the hospital to make sure she's taking what she needs and that she's not getting any double doses. If Karen has concerns, she will need to call the client's family doctor and or the community pharmacist. It is nice when all hospitals provide explanations why prior home medications were discontinued and why new medications were ordered. The client always wants to know why, and the nurse hates to guess why, but does use her professional discretion. The rest of the day, Karen will spend time seeing the following clients: always subject to change, especially if her phone should ring. Another client she's seeing will require fragment injection and teaching the daughter how to administer this injection. Another client with a post-op wound infection after bowel surgery. One client just about ready for discharge. The client and family now know how to suction the tracheostomy and how to change the trache's inner and outer cannula. They have really developed the confidence needed to do this and have accepted the realities of this permanent change in the lifestyle. And her last visit of the day, that return visit to her MRSA client. Finally, knowing that the clients have been seen and the paperwork is done, Karen reflects on her job as a home health nurse and feels good about the difference she has made for her clients on this day. The home health nurse does make a difference for their clients in the community every day. They try to see beyond the physical needs of the client they visit, citing many situations in which the psychological aspect of care provision is almost as important as the clinical. An example from a true story. A client was housebound, very ill, immobile, obese, for 2 years, losing all the vibrancy of his former life. He got to the point where he felt hopeless. He was so isolated and alone. But underneath his depression and reluctance, the nurse could feel that he wanted his life back. Over 18 months, the nurse transformed empathy into action. The nurse helped the client obtain appropriate medical equipment and find ways to reach out through the internet and email. The nurse also encouraged the client's pursuit of apartments better suited to his mobility challenges. The client wrote to the nurse's supervisor, "During the time my nurse looked after me, they did so with professionalism beyond reproach. They had concern, compassion, and respect for my well-being. They endeavored to lift my spirits, mostly with suggestions and ideas to improve my way of living." When the nurse was asked what they got in return for how much they give, the nurse's answer is, "I just picture my client getting out, living a more normal life. That's a good thing. What I did doesn't seem out of the ordinary. I know I helped, but I'd want someone to do the same for me." So let's look at the realities and challenges in home health care. The client, family, caregiver is the unit of care requiring a different set of skills to navigate. Hospitals have very controlled settings designed for health care. Home health nurses are guests in a private home that are designed for living and not providing health care. Once that nurse leaves the home, we're never 100% sure what the client may or may not be doing. There is a shift towards increased acuity, coming home earlier with lack of preparation, knowledge, capabilities to mitigate the risk or support. Illness and conditions, albeit complex, is only a portion of their lives and is superimposed by all the other life issues that they're dealing with. So perhaps any marital, family relationship issues, financial issues, employment, life transitions. The frail elderly with complex medical, emotional, physical, functional, and social concerns. They are in their home, oftentimes alone. The ethical and cultural safety considerations. Here we're asking family and caregivers to provide care that only a day before was provided by a trained professional in an institution geared for health care. For example, we're asking family members to give injections, to suction, to change catheter bags, sometimes to do a dressing. We can engage them in conversation and collaborate to mitigate risks, but at the end of the day, they make that decision to eat that extra piece of cake or keep their grandmother's throat up. Oftentimes, we ask family and caregivers to inflict pain, participate in intimate acts, or without attending to their needs or capacity. The mental health of identified clients and or family or caregivers are traditionally not considered. We deal with the vulnerable and abused clients who are asked to open their homes to multiple providers. Human factors that apply with the recognition of potential risk with family caregivers providing most of the care 24/7. The increased reliance on family and caregivers without attention or support to their needs. Human resources constraints, so the recruitment of regulated and unregulated providers. Within the hospital, some considerations are given to RN ratio for providing quality care within a relatively controlled and safe environment. In contrast, as the client moves into the home, the client or the family and caregiver is expected to take on similar duties without the support or infrastructure. Challenges of maintaining continuity of care through transition and coordination across all sectors of healthcare. Technology is not really designed for home care, though it is becoming more important. There tends to be a lack of a communication infrastructure and the electronic health record being shared. The pace of new technology, supplies, and medications is so great, the RNs are often running to catch up, so they hear about new procedures only upon a referral of a patient to home care. Home care takes up a big chunk of home care, and we tend to take care of the whole, not just the whole. Infection control. With post-acute care, central lines, the frail elderly, wound care, level of cleanliness in the home, palliative care. It is becoming very important in the home care setting. Many policies are developed, example through Health Canada, through PDAC, that tend to give minimal consideration for the home care reality. So in summary, it should be expected that the home care nurse as a component of the home care team will be increasingly in demand as the health system transforms to care in the community. Working as a team is effective and ensures that the outcomes realized are greater than the sum of the parts. In other words, value is realized. Within home care, various constellations of service providers must be supported to work together to address Ontario's health priorities. Nurses practice autonomously in the community sector and as members of the team apply critical thinking decisions about performing essential care. They consider the appropriate health provider for the individual based on a detailed assessment and the consideration of the person's future needs. Nurses undertake to provide clear, accurate, and concise information about a client's condition when transferring care. With the aging population and the increasing emphasis on care at home, the paradigm is expected to shift from the hospital to the community. The Canadian Nurses Association predicts that 2/3 of nurses in Canada will be working in the community in 2020, compared to 30% in 2006. Thank you everyone for attending today's presentation. I hope you found this presentation informative and that you might one day decide to take on the challenges and rewards of being a home care nurse. Thank you again.